Hi, I'm an endo warrior and endo advocate, and I stand with you. Hi, I'm an endo warrior and endo advocate, and I stand with you.
All right, good afternoon, everyone. Thank you for being here with us for today's E for Endometriosis free quarterly Zoom session. In fact, this is our final quarterly Zoom session of the year 2025. These sessions are part of our ongoing commitment to raise awareness, empower individuals, and provide reliable knowledge for the endometriosis community. Myself is Hafezah, and I'll be your host for today's session, organized by E for Endometriosis. So like many of you here, I'm also an endo warrior. I was diagnosed with the condition in my early 30s after doing a fertility test. And I was told by my doctor that I probably had it for a very long time. And I'm sure a lot of you with this condition can relate when I say I wish I had known this earlier, so that I could repair the damage before it affected other things in my life. Hence, it's truly a privilege to share this space with you all today, so that together we can raise more awareness. Before we begin, here are a few important housekeeping guidelines to ensure a smooth and respectful session for everyone. So firstly, please switch on your video as much as possible during the session to promote mutual participation. Stay muted during the presentations to avoid any interruptions. As well, remain kind and respectful in your words and actions throughout the session. And lastly, take note that this talk is only intended for general awareness and wellness insights. So for more personal medical concerns, we encourage you to consult qualified healthcare professionals. And take note that this session is also being streamed live on our E for Endometriosis YouTube channel. So if you miss anything or want to revisit today's insight, you can always catch the replay at your own convenience. And lastly, we're also using Pigeonhole Live to make sure that your questions can be seen during the live stream. So you can scan the QR code as displayed on the screen to submit your questions at any point of time. And you're welcome to also vote for the questions you would like prioritized during the Q&A session. So today we are honored to welcome Dr. Eleanor Loh, a medical doctor and endometriosis patient herself. With lived experience on both sides of the care, she brings a rare and powerful perspective to the conversation. Dr. Eleanor will share empowering insights on how patients can better advocate for themselves and seek care that truly honors their whole experience. Dr. Eleanor, the floor is yours.
Yeah, hello, good morning. Oh wait, it's afternoon. Okay, hi, I'm Eleanor. So today I'll be talking about how we bridge the gap and my perspective on endometriosis. Yeah, so more about me is I'm 26 this year. I've had and fought endo for the past 15 years. This is my third year of being a doctor, so still very, very junior. And also, similarly, I'm about 3 years post my excision surgery. Yeah. So we'll talk about my journey first. It does give some context. So uh, from early childhood, without even knowing it, I grew up thinking that it was normal to hurt really badly when I take a poop. And it didn't matter what I did, what I ate. It just felt like my whole body was being torn apart. It is actually a part of my endo symptoms, but nobody knew about it. Even I didn't think it could have been until after my surgery and it stopped. So at puberty, had my menarche, so first menses, about the average age of most Singaporean girls, about 11. So at first, it started as a mild cramping, and then progressively over the years, it got worse and worse and worse. So I think this is something that was initially taken as, yeah, this is quite normal, period pain. So I didn't really think about it until it really started to affect my quality of life. So it got worse and worse, and I was having to take a lot of MC, a lot of painkillers. Back then, it was mostly still like self-medicating or seeing a GP, and it was just Panadol and NSAID. So I usually took ibuprofen. And then after a while, I think in my later teens, so like 15 plus, then I started seeing ONGs. Some were not very sure what was going on. Some just dismissed it as a normal teenage dysmenorrhea, which is just painful menses. Or some just didn't even want to talk to me. They just spoke to my parents alone, and then they just made me take hormone pills without really explaining what was going on. And then I had a lot of side effects, and actually, I would say if I had known back then, I wouldn't have taken the hormone pills, or that I would have asked to change the type of medication I was on once the side effects got very unbearable. So one of them made me so fatigued and so nauseous that I just couldn't study, couldn't really do anything. Basically, I was just dragging myself to school and then coming home and just collapsing in bed because I just couldn't stay awake. Um, and at that point, I just couldn't really understand why. So this went on for a while, until I just really just completely snapped, and I was like, okay, no, enough. Just refuse to trust any more doctors, refuse to take anything other than pain medicine, and just try and power through lah in general. So eventually that led to me starting medical school about 18, 19, and things were roughly stabilized by then in terms of the pain. It didn't get any better, but for a few years it didn't really get any worse lah. But it was still very much affecting my quality of life. I definitely was not as active, not as social as my peers, and I definitely felt like I wasn't performing to my actual potential. So turning 20, I really started to realize that the endo was, or well, the pain by then was just really not tenable. I was starting to be posted into the hospitals, and I really was struggling with the clinical work, and then ex-boyfriend dumped me because I was always tired, always in pain, and never happy, among other things. That and getting into medical school itself, it was for me kind of taking back my autonomy, because I figured if I don't trust anybody else to take care of me, then I should try and do this myself. At least I try and manage myself, or be able to be taken seriously because I speak the same lingo and I've studied the same things as other doctors. So that's how I got there. And then afterwards, in my fourth year, so that's about 21, 22, I went through ONG as part of our normal curriculum posting. That's where I met Dr. Mali, who is one of our strong supporters of E for endometriosis as well. So got to know her in a more general fashion, realized that actually not all doctors act like the ones that I've had the misfortune of encountering in the past. And her kindness and her knowledge on endometriosis was something I was very heartened by, and it gave me a bit of hope, which was very important because the subsequent year, my pain started worsening rapidly. It was spreading all over my pelvic region, abdomen, and even up to my chest. Even breathing was fundamentally painful. And the hormone pills that just tried to restart, initially I was on combined ones, so more, I guess, normal birth control pills. It did nothing to control the pain. At that point, I was getting breakthrough bleeds non-stop as well, even though I was taking the pills continuously. So I was really just at my wit's end. I just reached out to Dr. Mali, and we did the whole workup. I had my ultrasound done, MRI, and even CT, because of how this spread out my symptoms were. And it confirmed not just endometriosis, but bonus things that I'll talk about later. And for a long time, I was actually very resistant to having surgery, because while I knew it was an option and it was the definitive treatment from my readings ever since my teens, I was just too scared, and I just didn't have enough trust in anyone to actually do the surgery for me. So by then I had accepted that, yeah, I just need this to stop. But I still wanted to try and hold out until after graduation. It didn't really work out because it just kept going. The pain just kept going. I ended up having to see a pain medicine specialist. I tried a huge amount of pain medication, all the way up to like morphine, oxynol. So those are strong opioids. And I was just forced to take huge amounts of HL, not just because I couldn't do the posting work, but also I was just in so much pain. I was just screaming in and just lying in bed, just really just not in any way remotely human looking. So by then I had committed to doing my excision urgently in the middle of the school year. So this bonus thing that I talked about just now was that on all my scans, because it scanned everything from chest to pelvis, we found actually there was a spleen nodule that we weren't sure what it was. In fact, it was so ambiguous that the report said there is something there, but we don't really know what to call it or whether it is actually a thing. So we decided also during my excision surgery, we get in a liver and spleen surgeon as well to explore the area and just remove anything and everything that looked abnormal. And because my endometriosis also was heavily affecting my bowel and my rectum, given that there was all these symptoms from when I was young. So we also had a colorectal surgeon on standby in case we needed to do more invasive work with the bowel and I might need a stoma. So it was really just unbearable, and we booked the op. I got it within maybe a month or so. Yeah, we booked for about 6 hours in my case. We used only 4 hours though. So officially, 33 lesions of endo were removed. That makes me stage 4 based on O classification. Plus also, there was indeed that spleen nodule thingy that we saw on the scan. My surgeon removed it, and he also happened to find another benign growth, which is a focal-nodular hyperplasia on my liver. So as per my instruction, he just removed everything that was remotely abnormal. So it was quite an extensive surgery. And in my immediate recovery also, while I would say the pain relief was almost immediate, my pain reduced by 90%. I, I was shocked when I had my first bowel movement after my op, and it felt like nothing happened. I managed to avoid even more invasive surgery. So I avoided a stoma, avoided a diaphragm, really pure out of pure luck. Though I had bad effects coming out of anesthesia, so I had a lot of vomiting and a lot of nausea for 1 week afterwards. Yeah, so this was the first photo I took after my op. Yeah, I really couldn't believe I was alive. So 1 year after, so I still had some residual pain. So the 90% pain reduction was really the lowest of the pain that I had ever experienced. And then slowly there was some pain that came back. So that after a long time of investigating and trying different medication with my pain specialist, we figured that it's probably central sensitization. So this is a concept I'll explain in my subsequent slides. Now I also have what I would say is probably complex PTSD from over a decade of pain and medical trauma with all of these experiences. Also managed to graduate, and after after about half a year or so of being post-op, I changed from oral Dynogest to getting a Mirena because I still had persistent adenomyosis, because that was something we couldn't operate on, and also because I was starting work and having problems with missing pills from being on call overnight and just general exhaustion from work. So at least the Mirena was there to constantly release hormones without me having to manage pills on a daily basis. Which leads us to now, which is 3 years later, and me here being able to share all this with you. So let's talk about mutual understanding. So I think one of the things we find very difficult as patients is understanding why doctors ask or do certain things, and what this means for your care and your treatment, and how to optimize these things. So firstly, this is everything that can happen in the abdomen or pelvic region that causes pain. So this is a table from the European Association of Urology. It does include endometriosis here. I wanted to show this because it includes almost everything you can think of that happens in the pelvis that causes pain. So endo is just one tiny little thing here. So how do doctors narrow all these things down to just endo? It's a lot of things to think about. So it is partially a few things to talk about. So firstly, the concept of pain. So pain is not just pain alone. In medicine, we classify pain into 3 kinds of pain. First is nociceptive, which is direct pain from a stimulus. Like if you stub your toe on the table, you directly feel pain at your toe. or if you get a paper cut, you feel that pain on your fingertip. That's the direct pain. That's nociceptive pain. Neuropathic pain is something that is from nervous system damage. So, for example, like shingles pain or slip disc pain, because those are involving injury to the nerve. Like slip disc will be nerve compression and things like that. And the the one I highlighted, nociplastic pain, is something that is less understood and actually a relatively newer concept. So this is pain that comes about from altered pain processing. So there are links from direct pain stimulus um, and the perception of pain, despite there not being anything that is directly causing pain. So, for example, in my case, I felt pain in my chest area, even though there was no endometriosis or there was no tumor that was directly causing pain. I didn't have any clear signs of nerve damage from like shingles or slip disc or other nerve injuries that were causing pain, but I still felt pain in my chest area, and there wasn't a clear cause why. So that falls under nociplastic pain. So in the context of endometriosis, nociceptive pain, which is the first one, the direct pain stimulus, will come from things like pain from cysts. Sometimes the cyst can grow very big and they twist on itself. That causes torsion, so that can cause pain. Adhesions that cause pain, because when things stick to each other inside the pelvis or the abdomen, and your gut moves due to digestion, that tears and that pulls on things and causes pain. Neuropathic pain in endometriosis, I think it's a bit rarer, but it does happen on occasion. It's where the endometriosis lesions grow into and invade nerves, and that causes nerve damage there as well. And nociplastic pain is what I find actually is a bit more common, is that because we have felt so much pain in our various manifestations of endometriosis over the years, and may or may not have been treated adequately, this pain, all this pain stimulus can cause firstly, so there are some brain changes here. So in a, you could say it's brain damage, but not really. It causes pain to be perceived where maybe the endo isn't flaring at that moment, or maybe there isn't anything at that moment. It's not to say that the pain is in your head, it's that the pain has short-circuited your pain processing to the point where it's just randomly glitching and creating pain signals out of nowhere. That's what happens. Okay, so to go into more detail, so it is a process in which the nervous system, both the nerves as well as the brain, undergoes changes that change the processing of pain and other sensations. So in certain other cases, a light like touch or stroking on on any area, for example, some people have it on the arm, can be mistranslated into pain. So that is called allodynia. So that is something that can also happen in in this class of pain things called nociplastic pain. And it can also be thought to be the reason why patients have a lot of unexplained pain and fatigue. And I know that endo fog and endo fatigue is something that we very commonly experience, but isn't really spoken about in a medical context. We don't really have a proper label medically to explain why we have such amounts of tiredness and fatigue out of the ordinary. So the problem with nociplastic pain is that it gets worse and worse and worse each time it happens, because it's a positive feedback loop. When the pain comes, you feel that pain, you get affected by it, and then it continues to feed the stimulus and continues to train your body that there's going to be pain, there's going to be pain, and eventually it's almost as if you are preparing yourself to always feel pain. So pain, how to talk about it to your doctor. For us, when we take a history, this is the most basic way we are taught to address pain. So it's called the Socrates system. So usually this will go into like our mental checklist, like where's the site of the pain. So some of the things that can be helpful here will be telling your doctor where exactly the pain is. So you can talk about it in quadrants as well as the suprapubic region. Of course, uh, it may not be in neatly in a particular quarter, but having an idea of how of like what regions correlate to what things may also be helpful in figuring things out yourself as well. So the right upper quadrant usually contains your liver. Left upper quadrant is usually the stomach and your spleen. Right lower quadrant and left lower quadrant are your intestines. The right side will also bonus have your appendix. So if there's something that you still have, then that can be a consideration that may be causing you pain. And then in the middle here, um, slightly lower is the suprapubic region. That's where the uterus, the ovaries, and the tubes, all that are. So that is usually the focal point of endometriosis pain for most people. Next thing will be how to describe the onset of the pain. Is it a sudden pain or does it gradually creep in? What time of the day does it happen? Is it associated with any activity? So that may give you a clue as to where this pain is coming from. And the character of the pain also is very important. So cramping, tearing, burning, aching, these are all different ways you can describe pain and more. So commonly for adhesion type of endometriosis, you may feel pain that can be described as like tearing, or like what I like to describe the texture is like tearing tissue paper. That's what it feels like to me as a patient, like the tissue paper is being torn inside me. Or cramping, common with adenomyosis as well. So it's usually cramping from during the menses or even cramping of the intestines when there's bowel involvement and that upsets the intestines as well lah. So radiation may not necessarily be seen in endometriosis, but how to describe it is like, for example, if the pain spreads from like the front, goes to the back, or it moves lah, basically. Like the pain is like in one spot, but it moves to somewhere else. So that's called radiation. And any associated symptoms will be like stuff like nausea, vomiting, cold sweats, headaches. So stuff that happens with the pain or is directly caused by the pain. So that also helps us classify like how severe the pain is. Timing as well. So like before, during, or after menses, all the time, no matter what. After exercise, once off jolt of pain, or is it something that comes in waves over like a few hours, or is it like constant pain for a long period of time, etc. What we also want to know is if there's any exacerbating or relieving factors. Does any medication work at all? Like any specific medication, any TCM even, if there's something you try, or does TENS work? So that's the transcutaneous electric stimulation. Or is it something that is worse after doing some activities? For example, is it something that gets worse if you have to walk around and be active in your daily life? Or is it something that gets worse like after sexual intercourse, things like that? And severity, that is the one. So the problem with severity is that our doctors are usually trained to ask on a scale of 1 to 10, 10 being worst pain of your life, what's your pain? the problem is, how do you know you've experienced 10 out of 10 pain? Usually people say this is like kidney stones or childbirth, but not everyone experiences these things, or not everyone feels that those kinds of pain are truly the worst kind of pain in their life. So it creates a problem of if I say 10-10 pain from endometriosis, which maybe I do perceive it that way, the doctor on the receiving end of the answer may feel, no lah, this one is exaggerating, or like, are they sure it's 10-10 pain? It creates this kind of miscommunication, and I find that to be very, very detrimental in not just taking the history and understanding the pain symptom, but also in terms of the doctor-patient relationship, because it just means that your doctor isn't listening to you. They aren't trusting you to 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 give them an accurate reflection of the pain. And what if you did have you did have a kidney stone, or you've given birth before, and that was the 10-10 pain, but suddenly you experience endometriosis pain or some other kind of pain, and that blows past all of that. Then that also calls into question, like, how have I been describing pain anyway? Is that therefore a 11 out of 10, 12 out of 10? But that doesn't really make sense, and the scale doesn't extend that far. So what I personally prefer in terms of pain history is to also add in the specific question of, how does the pain disrupt your daily life? Is it something that is uncomfortable, but you can kind of grit your teeth and get through it and continue your day-to-day activity? Is it something that you need to sit down and rest uninterrupted? Is it something that keeps you completely bed-bound? Is it something that is like you're screaming, you are in horrific pain, you just want it to end no matter what it takes? Are you so desperate as to be pushed to say, like, I don't mind dying if it means the pain can stop? So I think that is something that is missed out when you look at numeric scales from as most people do. So I would really suggest that even if your doctor doesn't mention how doesn't ask you how pain affects your daily life, that you volunteer this info and you make it very clear whether or not how you live with this pain, and that will help you be taken more seriously and be and get more mutual understanding on how all this affects you. Okay. So, so some things in my experience, in terms of optimizing your time in speaking to and with a doctor, is that actually in medical school, we are trained to limit our consult times to like 7 to 15 minutes. In fact, the shorter the better, because our patient loads across the board are very, very high. Especially if it's a more general clinic and not a specialized, like for example, endometriosis clinic, where perhaps the doctors are allowed to book patients for longer periods of time. So the problem is, patient loads either force consult times to be shortened, or it makes clinics overrun, and therefore puts a lot of physical burden on your doctor. So that means that they may be a lot more tired, and they may miss things, or they may not be so energized as to dig for as much info as one would provide here. They may expect that maybe the patient will just volunteer all these things on their own. Sorry, excuse me. Yeah. And also, the problem with consults is that when we ask for history and we are asking a lot of questions, it can be quite triggering for those of us with trauma, be it medical trauma from poor experiences in the past, or even sexual trauma, because inevitably with things that involve the reproductive system, we will have to ask about marital history, sexual history, even say what you experience during intercourse, after intercourse in terms of pain, and even need to do pelvic examinations. So what I find very useful is to bring a written list or chart. So you can look at the Socrates slide from earlier. So just put down your pain symptoms and describe it accordingly. And sometimes people come in with calendars or bullet journal, like habit tracker looking things, and they chart by score or by color or in whatever system that they find useful, the way the pain affects them over say a month or a few months. And that gives us a very good visual way to talk about the pain. It also helps if you can come in and tell us about your menstrual history, patterns for the past 6 months, maybe a year, and family history. And the thing is, bringing things written down in advance is helpful because sometimes you panic. There's a lot of things, there's a lot of questions, you're interrupted partway when you're telling your story. And at least having it all on paper ensures that what you want to convey to the doctor is there. You can either just show your doctor or you can read off it. And of course, bringing someone who is supportive and can help speak up on your behalf, either when things are being overwhelming for you, or if you have difficulty asking for certain requests of certain help. So that may be helpful to have a support person. And one more thing about writing down is that if it's difficult to voice out, to verbalize to another person out loud that you have previous like trauma or sexual trauma, that may limit certain things, for example, having an internal ultrasound or pelvic examination. Having it written down and just showing the doctor or the nurse can help to mitigate triggering yourself by having to force yourself to say it out loud. So that's something that you can consider as well. So apart from ONG, there are quite a few others professionals that can help. So colorectal surgeons, so they are usually involved in severe cases of bowel endometriosis. So they will help with they will help the ONG surgeon together remove the endometriosis spots that may be more invaded onto the bowel. They may make a stoma, which is to divert the intestine contents out onto the skin surface so that it drains into a bag so that the intestines that have been operated on inside get to heal without having to be stressed by having fecal matter pass through it all the time. Of course, the stoma in a lot of cases is not permanent, so usually that involves a second surgery to put everything back in. Pain medicine specialist, so this is usually an anesthesia doctor who has subspecialized into pain management. So they can help for pain control in terms of trying other medications that are beyond what is what most GPs and ONG doctors will be comfortable giving. And because pain can cause a lot of emotional and psychiatric side effects in terms of the pain directly causing depression or the pain affecting your daily life to the point where you feel like your life is out of control, or you just or it's just the pain has caused you to lose opportunities, affected your life, and that's caused emotional distress. So I don't think anyone should be ashamed to reach out to anyone in the mental health field, be it like a psychiatric doctor, a psychologist, or even a therapist to talk about it, because pain is a strong contributing factor to poor mental health. And the worst thing is that poor mental health actually um, it can exacerbate the perception of pain. So it also creates a very vicious feedback loop in that it feeds into and worsens pain if you're not emotionally well. Of course, it's hard to say that you're emotionally well or happy when you are experiencing chronic pain, but at least having some form of support and learning to manage things or getting medical help in that regard can help to smooth things over. And lastly, one more thing which is quite important will be the pelvic floor physio. So usually pelvic floor physios they come in to help with this thing called hypertonic pelvic floor. So in the same way that you can get muscle aches and muscle stiffness in other parts like your shoulders, your back, that can happen to your pelvic floor as well because of chronic tension from pain. When you feel pain, for example, in your shoulders, you tend to tense up. Same thing goes for everything down below as well. So that itself is also an additional source of pain that it can be managed and even remedied with some physio work. And of course, the pelvic floor physios, they may also be able to help with things like vaginismus that can help to get you to be able to tolerate internal scans or examinations better in terms of the workup for endometriosis. Of course, it will help with future intercourse or childbirth in the future. And pelvic floor physio, even after having excision surgery, is very useful because it helps to keep your pelvic floor mobile and prevent adhesions from forming as easily. So talking about how we work up endometriosis, there are a few methods of diagnosis. So um, I think most of us, from reading, we know that the gold standard is diagnostic laparoscopy because you directly see the endo with your eyes and you can immediately remove it and send it to the lab for testing. That is, of course, the most clear-cut way of dealing with the endo because you're already removing what causes pain. But there are things and caveats to note, which is that there's a high upfront cost and it can be logistically challenging to arrange because you need to take HL, you need to think about who's going to take care of you post-op, insurance coverage, things like that. And it is an operation still, so there is risk from being under general anesthesia and having surgery. And to begin with, you need to be medically fit enough to be able to go through surgery. The other thing is also that not all surgeons are the same. So some may not be as comfortable removing every single lesion that they come across. Some may be. So it is something that you need to really discuss with your doctor whether they are comfortable doing this upfront or if they would be keen to refer you to someone else who can do the surgery more thoroughly lah. Yeah. So there are other ways of diagnosis. So these days we can do a transvaginal or transrectal ultrasound. So this is a scan that can be done during the consult itself with an ultrasound machine. The thing is that it's an internal scan. So the probe is basically a long stick and it goes inside. So this can be difficult for patients with vaginismus or previous sexual trauma or other reasons as well lah. So it can also be done through the back passage, but again it is also similarly uncomfortable and the same issues with trauma can apply as well. It is quite useful in terms of diagnosis of endometriosis, but it doesn't necessarily exclude endometriosis if it doesn't see anything there, because scans are not 100%, and a lot of times the resolution on these machines is also not sufficient. MRI scans will be the least invasive option. So what happens is you lie in a machine. Is basically a tube. You go into the tube and you lie there for about 30 minutes to an hour, and it creates a huge amount of noise, and it has to scan you while you're being perfectly still for the duration of time. So again, it is a bit easier to tolerate if you are able to sit through the noise, or you don't have any contrast allergies and no claustrophobia. The cost, of course, is a few times more than the ultrasound scan, but it can be useful to look at it in a 3D perspective. And if you really, really cannot tolerate having an internal check. Okay, so moving on, we'll talk about pain management. So this is the modified WHO pain ladder. So this is a recommendation from the WHO from in terms of how to increase pain medication to address pain. So usually in the GP setting or most ONG setting, you are going to be prescribed Panadol, ibuprofen, naproxen, Acoxia, or other NSAIDs. So these are very common medications. In fact, you can even get it over the counter for most of them. The thing that comes with prescription will be stronger painkillers. For example, tramadol. This is a weak opioid, which most doctors that are non-pain specialists are usually comfortable prescribing up to, because it is not as strictly controlled as other things like morphine. So usually where I would say you should think about requesting for a referral to a pain specialist is when you feel that if you are already getting a weak opioid, for example, tramadol, and it's still not controlling the pain, I think it's time, it is reasonable also to ask for a pain medicine referral, because they can give you different kinds of medication, not just opioids, if that is something that you are scared of. There are other things, for example, anticonvulsive medications. Those help with some neuropathic pain as well as nociplastic pain. So these are like gabapentin, pregabalin, as well as some other kinds of medications that usually pain doctors will have more access to than anyone else lah. Yeah, and also if you're getting towards this point, you might need to think about escalating your current endo treatment. If you weren't on hormones before, maybe it's time to consider trying, because that may help to halt the progression or at least dampen the symptoms a little bit. Or if you've already been on hormones, maybe it's time to have a revisited discussion about getting surgery to stop the pain. Yeah. So on surgery itself, there are actually some things that you may not realize or read about or even be warned about in advance lah. So one thing you may not consider is until you're asked it, and I was asked this question actually, if the endo affected my ovaries, would I still want them to remove the endo there? Why? Why does it matter? It's because having to operate on endo directly involving the ovaries can cause collateral damage, and that can potentially reduce your ovarian reserve. So that can reduce the number of eggs remaining and therefore affect future fertility. Or if the endo is encasing the whole ovary or it's completely invaded, then you might actually need to lose that whole ovary. It's hard to say. And that can be something that is not easily decided on in the span of like 5-10 minutes of consultation. Not to mention if any ovaries are being removed, that also puts you at risk for premature menopause as well. And that also causes a whole host of symptoms that can be challenging to deal with on its own. Another thing about preparing for surgery is that if there's a lot of suspicion that there is bowel involvement of your endometriosis, you may be asked to do bowel prep, which is like before colonoscopy, you have to drink a few liters of water and basically pass out everything, clean out the insides of your gut. And for those of us who have a lot of issues with pain in passing motion, that can be very, very difficult to go through. For myself, it was almost torturous having to do my bowel prep before my op actually, because I just you're basically glued to the toilet. You're having to pass stuff almost constantly for hours and hours before. And that was triggering off my pain so bad because I had a lot of adhesions between my rectum and my uterus. So every time there was movement in the area, wow, it just felt like everything was tearing apart. So just be aware that you may be asked to do these things and be mentally prepared that it may also come with discomforts as well. And during the operation itself, to access the posterior part of the uterus, an instrument may be inserted into the vagina to manipulate it so that it's angled in a way such that it opens up the back for the surgeon to be able to access the back. If not, it may be like folded down and it's kind of like closed off. So yeah, that's something to consider, particularly in the context of like sexual trauma or even just not having been sexually active before, or even if you're just uncomfortable with the idea, it's it's probably inescapable if you do need the surgery because it is really important in terms of positioning. But at least going into it with your eyes open and aware that this is something that may happen will at least help with being mentally prepared. And as with most operations that require general anesthesia, you'll most likely need a catheter post-op for at least the next half to 1 day, potentially more. This is so that you can pass urine while you are still under the effect of anesthesia, because you are not considered really safe to walk independently to the toilet for at least like the next 4 to 6 hours minimum. So it's not that you can just pee into a diaper. It's because the anesthesia can also reduce your ability to feel when your bladder is full and therefore pass the urine. So therefore the catheter is there to protect your kidneys and protect your bladder from overflowing and backflowing into the kidneys and causing kidney damage. So after the operation, maybe you've healed up and it's like half a year later, why do you still have pain? So there can be a lot of reasons actually. First one can be there may still be endo there. Maybe not everything was removed. Sometimes the endo spots can be so small that even if you're looking directly at it, you can't see it, and therefore it wasn't even identified to be something that was removed. It could have been that it grew back. There can still be adenomyosis because adenomyosis surgery is yet another kind of surgery compared to endometriosis, even though adeno is a sister disease of endo. So the problem with adeno is that you can't really remove it unless you outright remove the whole uterus. But that may not be an option for younger women who still want to potentially retain fertility. Or if you don't do an adenomyomectomy, which is to remove just the adenomyoma, which is that part of the uterus that is affected, alone and leave the whole uterus in. But the problem is that it creates a lot of complications in future pregnancies, in that because you are cutting out part of the wall of the uterus for an adenomyomectomy, you're reducing its structural integrity, and it can cause the whole uterus to rupture during pregnancy, and that is life-threatening for both mom and baby. So typically, in most cases, you leave adenomyosis alone. So that can still be a huge factor for pain even after endometriosis op. And even after operation, new things can happen. For example, new post-surgical adhesions. It's not specific to endo itself, but it's a known risk of any abdomen or pelvic surgery, and it can cause pain. Because when you go and disturb all the organs inside, it creates an inflammatory response, and it can cause adhesions to grow between the organs. And as with adhesions, if it happens to grow between things that like to move, or peristyles, basically, like the gut, then that can cause pain as well. And of course, as I mentioned earlier, it can also cause central sensitization, which is a nociplastic pain. So all these years of endo may already have caused enough damage to incite nociplastic pain. And so that leaves you with the perception of pain even when there may not be a direct stimulus causing it. Yeah. So I think we'll move on to the Q&A. So
Thank you so much, Dr. Eleanor.
Hafezah?
Thank you so much, Dr. Eleanor, for sharing your personal story and for such an informative and eye-opening session. We do have a number of questions submitted through the pigeonhole. So will it be all right for you, Dr. Eleanor, if we extend this session until 1:40 p.m.?
Yeah, can.
Yeah. Okay. All right. Great. Thanks. Okay. So we will go with the first question, the most voted one. Why do many university medical textbooks and clinical teachings still frame endometriosis as a purely gynecological condition, relying heavily on the 1927 retrograde menstruation theory, when current research recognizes it as a complex multi-system disease? And how can education and practice be better aligned with today's evidence?
Okay, so it's quite a complex question, and it's a complex answer. So the problem with medicine, especially in that era in the 1920s and so on, actually even not until maybe the recent few decades, is that honestly, most of the doctors back then were men, and they don't really think so hard about women's conditions, especially not if it's something that is affecting a woman's quality of life. You'll see that obstetric research is a lot more developed, and fertility research is also a lot more developed. Why? It's because sexist prejudices generally make people look at women with the lens of women are just here to make babies, raise children, and so they don't really care about much else. And the problem is that with books published, it takes effort to overturn existing ingrained schools of thought. And while most people will say that they are practicing evidence-based medicine, which is basically research-backed medicine, I find that a lot of times this again doesn't actually play out as we think it should in real life lah. So the thing is for endo again, it was it's been stigmatized for many, many years, and a lot of us patients have been dismissed as crazy or just period pain only. And over the years, I think slowly the culture is shifting a little bit, but the problem with medical education is that a lot of it is rooted in tradition, and um, we are not so um, I find that in most places it's not so easy to introduce new concepts like this lah. That endo is not a cause of is not caused by retrograde menstruation.
Yeah, thanks for answering that. Hopefully there'll be more positive change in the coming years. Moving on to the second question. For those who cannot afford private healthcare, what are their current best options in public healthcare?
So current best options, well, of course that would be really to just start to get access to any ONG doctor in any public hospital. So the usual route would be to go to polyclinic, ask for a referral to ONG. There's only 3 hospitals in which there are ONG services in Singapore anyway. So that's NUH, KK, and SGH. Um, well, the thing is that with subsidized care is that when you first see the ONG doctor, it's not going to be an endo specialist unless you are lucky enough to be assigned one and they happen to be running the general clinic. So it will take time, possibly months to even a year to talk to someone who is better versed in endo than the common ONG doctor, because they will need to refer internally, get you the appointment, and then potentially do some scans or workup in between before they even refer you to whoever's their subspecialist within the department.
All right. The third question we have is how can someone begin advocating for themselves when they feel emotionally drained or powerless from years of pain?
Yeah, so advocating for yourself, it depends on what aspect. As I mentioned about optimizing the consult, you don't have to save up all the energy and show it during the consult in terms of like, I must have my story told during that one consult. I must get it done in that one time. So what I suggest is really keeping a log, maybe just write one sentence, um, or like just get a monthly calendar and mark off like how bad the pain is every day. Just keep track of these things so that you have that kind of hard evidence to show somebody that what you've been going through. Even if by the time you get to your appointment you're so drained, you just struggle with expressing yourself um in a way that gets you help lah. And of course, as always, will be to reach out. We have our support group in Singapore. We have global support groups. We have other platforms on social media as well, with a lot of endo warriors of like from different countries. And of course, if you really feel that your mental health is really in a very dangerous state, then reaching out to any medical professional, like your GP, polyclinic doctor, or even um, any other like even A&E doctor, um, can at least get you some kind of medical attention, either to control the pain or whether it's like if you're driven to the point of like wanting to potentially harm yourself or harm others, then um, psychiatric or emotional help lah. Because these things these things do happen, especially with how chronic and how pervasive endo is. Even myself, at the heights of my pain, I've I've been I mean, I was very much okay with not waking up anymore because that would mean the pain stopped.
All right, thank you so much, Dr. Eleanor. Moving on to the next question. What practical steps can patients take when they feel unheard or unsupported in clinical settings?
Okay, so if you've tried what I've suggested already, it depends on the way whether you feel it's an unheard because they don't understand, or is it being dismissive or rude. Now, if it's because you're unheard because the doctor doesn't understand or doesn't really appreciate the full picture, bringing in the written charts and written notes to show them can help with understanding. But if it's someone who is fundamentally, say, demeaning or rude, then I think it's um well within reason to just, you know, just kind of just abort the consult. Just stop, because there's no point putting yourself through even more distress when someone who you thought was supposed to help you ends up causing pain, being it physical or emotional. And from there, it's when you say, look, I want this to to stop, the next thing will really be to ask, is there someone else I can see instead? It's not to say I give up on seeking medical help at all, or I give up on this hospital. It's just, yeah, maybe just try someone else. Maybe they will they'll take you more seriously and more kindly as well. Because the problem with just giving up on medical treatment is that it really prolongs suffering.
Yeah, thanks for sharing that. Do you have any more questions? Okay, next one. What do you wish more healthcare professionals truly understood about the psychological weight of endometriosis?
Yeah, yeah, I definitely wish it was far better understood. Not just for endo, but really with a lot of chronic pain conditions, or a lot of chronic conditions that are generally associated with the stereotype of the I quote, hysterical woman. So this falls into things like fibromyalgia as well, endo, um, POTS, Ehlers-Danlos. So these are diagnoses that, when seen on paper, tend to invoke oh my God, this kind of thing again response in a lot of healthcare professionals. Um, why? Is because chronic chronic pain and chronic fatigue um, really affects the emotional well-being of the patient. And of course, if you have to talk to people every day, you have to see all sorts of patients, you don't it kind of wears on you if you are always seeing patients that are super unhappy, super depressed, even though it is part of your job. It is part of your job to heal. Um, I think a lot of it is also to understand, but it's hard too lah, without having lived through it, that it's not your patients being difficult or whiny or complaining a whole lot, or it's just that it's just the disease that affects them is just so so pervasive. You get a lot less of this kind of attitude in the context of, say, like cancer patients, because it's almost socially accepted across the board that, of course, cancer patients are going to be in pain, they're going to be depressed, they're going to be down, and nobody really faults them. I mean, in the context of healthcare, for, you know, um, always saying that their treatment isn't working, uh, or that, they're still in pain, or that they're just very depressed and are losing hope lah. So I think one thing is really just um to have better separation of professional work and whatever biases or opinions doctors may have lah.
All right. The next question is, endometriosis behave in ways similar to cancer, such as invasion, recurrence, spread beyond its site of origin, yet receives far less attention, funding, and multidisciplinary care. Why is it not given the same urgency on a dedicated holistic care framework within medical education and healthcare system? So similar to what you already mentioned, but do you have any more that you want to share about this?
So again, I think it goes back to my answer earlier about the way women are viewed historically. Maybe it's just, I mean, it doesn't actually really go on to directly cause death in most endometriosis patients. So nobody really looks at it as like life-threatening. It is life-impairing, yes, because of how badly endo can affect us in different ways. And it also goes back to my point about uh the way women have been viewed over the years lah. It's just if it doesn't really compromise on a woman's fertility or outright death, then usually these things get overlooked, particularly in historical medicine.
That's interesting because it does affect fertility, but
Yeah, it
yeah.
does. But I think the problem is that we only really understood the part that it affects of fertility like much later on. It wasn't as direct as other kinds of conditions.
Yeah. I guess that's the last question that we can take due to timing constraints. So we've come to the end of the session. Thank you all for your participation. For any additional inquiries, you can feel free to contact Dr. Eleanor directly via the platforms that are shared in your e-booklet. So a huge thank you to Dr. Eleanor for her time, expertise, and helping us unpack the lesser-known layers of endometriosis-related pain. And of course, thank you to each and every one of you for showing up today and for being part of this conversation and choosing to empower yourselves with knowledge. So if you missed any part of today's session or you would like to revisit any key takeaways, remember that the full recording will be available on our YouTube channel. So feel free to share it with your friends and family or anyone that you think can benefit from this. So before we end, I'm also too excited to share a couple of things. So firstly, it's regarding our most anticipated annual flagship event held every March in honor of International Endometriosis Awareness Month. So it is the Wear Yellow SG Endo March 2026. This event is powered entirely by volunteers consisting of patients, caregivers, and allies who believe in the power of community and education. So the 2026 theme is I Stand With You. That it focuses on mental wellness, caregiver support, especially spouses and fathers, and the importance of standing together as one community. So to bring this theme to life, we invite you to take part by submitting a short video of yourself. You can say I am an endo warrior, endo caregiver, endo specialist, or endo advocate, whichever that resonates with you the most, and I stand with you. And as you say this, you can make the E sign with your right hand as shown in the sample video on the screen.
Hi, I'm an endo warrior and endo advocate, and I stand with you.
You may also include your name or how you wish to be addressed or your occupation, or simply mention your industry if you prefer not to disclose any details. So these videos will highlight how endometriosis impacts people from all walks of life. They'll be featured during the event and in our awareness campaigns. So we really encourage you to send your email, send your video to imnamira.e@gmail.com by the 15th of February 2026. And by doing so, you're giving us consent for us to use your videos solely for awareness purposes. So our flagship event, Wear Yellow SG Endo March, will take place on Saturday, 28 March next year at 10 Square Orchard Central from 11:30 a.m. to 4 p.m. Tickets will be available next month, so do keep an eye out on our website and social media pages for updates. So we truly hope to see you there. The other announcement is that I also like to share that E for Endometriosis is now live on give.asia. Our campaigns aims to help sustain our ongoing awareness work and ensure that our free Zoom call sessions and resources like this one can continue reaching more people who need support and understanding. So if our work has touched you, or if you believe in creating a more informed and compassionate world for those living with endometriosis, I humbly invite you to contribute. Every donation, no matter the amount, will help us keep these conversations going. You can simply scan the QR code that you can see on the screen and contribute to that. Thank you so much for helping us continue this mission. Thank you once again for being here. And until next time, stay safe, stay empowered, and do not stop advocating for yourself and for others. See you next time. Bye.